Okay, so congratulations, you got your funding, you built your company, you've got these milestones, you've been to Health Canada, maybe you've been to the FDA as well, and you're out there commercializing and you realize, oh dear, I haven't figured out who's going to pay for this. So this is something that's really important. Willingness to pay, right? You know, you can have a lot of customers. You can have a great price. You can have a great, distance between the problem, the solution's big. Lots of customers. But if you don't have somebody who's willing to pay, then you got a significant problem. So this is another one of those pieces that you may not need to do a lot of work on in the early stages, but you definitely want to be thinking about this as you're building your companies, as you're coming up with the idea, understand where that payment is going to come from. And so what we're going to do today is we're going to go through very high level, and I hope we accomplish it with the venture capital lecture, is just to give you a little sense, and so that you can start to think about it and start to ask the right questions. And really, if we've achieved that, if you've got enough information to start asking the right questions and finding people to talk to, then we've had success, because that's really all you can accomplish in about an hour. And we have about 50 minutes. So we'll walk through reimbursement. So the first thing to do is to define what the heck it is we're talking about. We don't have a ton of time. So, oh, that's odd. We're not. There we are. Okay. So we've got an inflation problem. Groceries are going up. Who shops at Food Basics? Yeah. Why do you shop at Food Basics?
It's the same product is priced cheaper at Food Basics. I've observed a lot of times bread will be $1 or $2 cheaper. The same product is cheaper at Food Basics, but it's maybe $2 expensive at Loblaws.
Right.
So it doesn't make sense to me. If it's the same product, why should I pay $2 more?
Exactly. That makes sense to me. I'm a Food Basics shopper. What about anybody at Whole Foods? Let's go right to the other end. Who shops at? Nobody shops at Whole Foods. Okay.
It's called a home check.
Whole check.
I heard from other people who said, which is true.
It's crazy. So where I got my vaccines, there's just down the street. There's a Whole Foods above there. And it's really nice to go and look, but yeah, crazy prices. What about Loblaws? Anybody shop at Loblaws? Yeah. Why do you shop at Loblaws?
Almost every grocery, because it's very close to my place.
Convenience.
So it's very convenient.
Yeah, I do Loblaws as well because there's one close to me. Yeah, convenience, absolutely.
And also I can collect the points.
Right. Yes, they got a good points program that you can get shoppers as well. So that's good. The loyalty points. What about Uber Eats? Anybody do Uber Eats? Yeah, that's kind of an expensive way to go shopping, isn't it?
But sometimes they have deals where it's like, I think like half off your entire like grocery bag, which I find is cheaper than if I were to go in store and check everything out.
Oh, you can actually get deals so that it is cheaper than going to the grocery store. Okay.
We do have those sometimes. I ordered mine yesterday. I got 40% off. So I basically paid 40% less than what I would have paid.
So you're getting all the value, you're getting the convenience, but you're not paying the price.
But they don't give them out too often, but whenever they do it,
you jump on it.
Yeah.
Yeah. Okay. Nice. Well, why the heck am I talking about groceries? Because really, it's the same thing. It's reimbursement. It's deciding what is the value, and what am I going to pay for that value? Am I going to pay for the convenience because it's close by? Am I going to pay for the nicer store? Am I going to pay for organic? or some name brand, the environment. There's lots of different points of value that grocery stores are selling, but ultimately, each of us every day are making these assessments, these value assessments. Do I buy a chicken breast or do I buy a chicken leg? Big difference in price per kilo. I'm getting more bone with the legs, and it's not a breast, so right. So I make a value assessment as I am shopping. Every time I take out my wallet, I am making a value assessment. Is what value they're giving me worth the money? Ultimately, that is really all payers are doing, right? And so instead of looking at food basics today, we're going to do the reimbursement basics. But it's the same model. If we put ourselves in the place of a payer, they just want to understand that if I'm getting the same thing and it's $2 less, why do I want to buy your? I don't want to buy your bread. Makes no sense, right? That's what payers are thinking. So as we go through this, put yourself in the place of the payer, and as you're building your technology and figuring out who's going to pay, you've got to do that to understand, well, what are they going to say when they look at this technology? So. The core takeaway. So I teach this course. This is a one lecture version of the course I teach at the University of Toronto. And the core takeaway for the entire course is really based on this picture. Anybody want to tell me what's going on here?
Is it the butterfly effect?
Butterfly effect.
Butterfly effect, yeah, exactly. That's right. So butterfly at the other side of the world, flapping its wings can cause a tornado or a hurricane. That's the butterfly effect concept, and it is true with medical device reimbursement as well. This focuses on medical device reimbursement, by the way. You need to understand your impact, and your impact on payers, on physicians, on nurses, on patients. You need to understand all your stakeholders. So we're going to talk about stakeholders. But if you take the time to understand your impact, you can't help but build a good reimbursement plan. So that's why we always come back to understanding your impact, both positive and negative, right? So we will talk a lot about that. So what is reimbursement? Somebody want to give me a definition?
I think this is something usually that healthcare providers like hospitals or clinics, they provide on a medical device, which is usually paid by the insurers that they are associated with.
Yeah, that's in essence what it is. I would simplify it. Somebody other than the patient pays the bill. Right? That's really what we're talking about when we talk about reimbursement. In this context, right? So that is the hospital, or it's the government, or it's the long-term care facility, or it's the private payer, the insurance company. So who is paying the bill and whether they have willingness to pay the bill are two really important questions. So this is the model that I built based on my time in reimbursement, and it does apply to drugs as well as medical devices. It's a pretty simple model to understand what your impact is, and then how to deal with that. So this is a Parthenon. You've got the ceiling, the roof, which is reimbursement, and that is based on 4 pillars, right? The stronger the pillars, the stronger the case for reimbursement, and then of course there's a foundation. So let's start with the foundation. Health Canada approval or FDA. You need regulatory approval. You need the regulatory authorities to say, okay, yes, you can sell this product and we deem it to be safe and effective, or at least we deem it to be safe. Health technology assessment recommendations. We're gonna talk a bit about health technology assessment, but ultimately, it's you and I at the grocery store deciding if we're gonna buy chicken breasts or if we're gonna buy chicken legs, or if we're gonna go to Food Basics, or if we're gonna go to Loblaws, right? Is it cheaper bread or is it convenience? What's most important to me today? So that health technology assessment recommendations, and then the 4 pillars from left to right. We have value offering. So that's that value proposition concept. So what problem are you solving? What is the value that we are getting as a payer, or as a clinician, or as a nurse, or as a long-term care facility? What is the value that you are offering? What problem are you solving? Strength of data. Okay, great. You're telling me a really nice story about how much value you're bringing to my long-term care organization. So can you show me the data which supports this? Oh, actually, but I don't have any data. Well, that takes care of that pillar. What you want ideally is to have a very strong value offering, and you want the data to support what you're saying. If this is going to save money, or if this is going to have a huge impact on patients, then the data should show that you're going to save money or you're going to have a huge impact on patients. Level of advocacy. So you've got a good value proposition, you've got some data that's supporting what you're saying. Who else is shouting from the rooftops? You're certainly shouting from the rooftops, but are there some key opinion leaders? Are there some stakeholders, some patient groups? Who is advocating for your medical device? If you've got good, solid support from key opinion leaders and patient groups, okay, there's another strong pillar. And then the last pillar is support or alignment with government priorities. So, for example, a few years ago, Ontario was way behind on hips and knees. And so there was a whole bunch of money that was invested specifically into hips and knee surgery. So if you were in that space, if you were looking for a reimbursement for a new medical device in that space, perhaps made it more efficient, faster, longer lasting, whatever that value offering is in that space, that's aligned with government priorities, your odds of getting reimbursed just went up. So those are the four pillars upon which you have your reimbursement case, and the stronger those pillars, of course, the stronger the roof, the better odds that you're going to get reimbursed. So that's the crux of what we're going to talk about today. We'll just pause there and see if there are any questions.
Health technology assessment recommendations.
Yes.
What's that based on? It sounds a very generic term,
Yes.
but it looks like it's a big foundation. So like
It is. We're going to get into
like
that.
a definition.
Yeah, we're going to get into that for sure. Yes.
Do you know any examples of like what the government is investing into right now?
They just came up with a diabetes strategy. The federal government just passed legislation, the Eye Care Strategy Act, something to that effect. I haven't looked into the legislation. I haven't looked into the strategy, but clearly they're passing legislation and investing some money into something to do with eye care. So those are a couple of different examples. Yeah, a rare disease strategy.
Yeah.
So that's another good example. Although this is the federal government. We'll talk about the different levels of government. They invested $1.5 billion, but it's still sitting in a bank account somewhere. They haven't done anything with it, much to the chagrin of some of the patient groups. But theoretically, there's a whole bunch of money in there for rare diseases. So there's another example. Yeah, good question. Yes.
Are there instances where the hospital buys stuff without the requirement of reimbursement? So
If the hospital buys stuff, then it is reimbursement, right? So we'll just take a step back. Their medical devices are a dog's breakfast. There is no reimbursement process. There is no process. That's what you're going to take away from today. So how you handle your reimbursement depends on your medical device. So come back to me at the end and ask the same question if it isn't answered. But these are the basic ones. There are other things that can impact reimbursement. So resistance to change, that's a very natural human thing that you and I have, and some physicians have, some government officials have. There are biases that we have to deal with. Insufficient billing codes. We're going to talk about billing codes a little later in the lecture. What the heck is a billing code? I didn't know. Billing code, oh geez. Change is not in my interest. You had a whole lot of radiologists a few years ago saying that this AI thing was a bad idea until they realized that actually it requires more radiologists, not less. And so now they've embraced AI. So we're all that way, right? If change is not in their interest, we're going to be more resistant. Yes.
Yeah, actually, I was thinking about like X-rays. Like, if you're selling a device to a hospital, like, does that fall under the radiology, or sorry, the reimbursement?
Yeah. So just to put a very a fine point on it, the way I define reimbursement is somebody else is paying, not the patient. So you have a medical device, and you want it utilized in the healthcare system. You don't want the patient to pay, but that's not entirely true. We'll get to the very end. But assuming you don't want the patient to pay, or there's not an opportunity for the patient to pay more precisely, then who's going to pay for it? It's got to be somebody.
Right.
Is it the hospital, long-term care? Is it a special government fund? Is it an insurance company? How do you be commercially successful?
Right.
And this is why it's important to think about early on in your process, because you may make some decisions based on who's actually going to end up paying for it.
So like anything that the hospital buys that patients potentially never even see technically as reimbursement because someone else is paying for it.
That's right. Yeah, exactly. Yeah. Hospital beds, cleaners, Band-Aids, wheelchairs, often put the cleaning stuff aside, but everything else I mentioned, they're all medical devices,
All the
right?
stuff that
Yeah, toothbrush is a medical device, class 1 medical device. A pacemaker is a class 4 medical device, but they're all medical devices. Yeah. Okay, so let's go back to focus on our model, and we're going to start with value offering and strength of data. No, we're going to talk about health technology assessment. That's what we're going to talk about. Okay, so health technology assessment. This is a whole area of economic study, so I'm going to do my best to just boil it down. Well, in fact, I already have, because we talked about the chicken breast versus chicken legs. We talked about raw bloods versus food basics. That is an economic assessment. In this case, we're talking about a health technology assessment, but it is the same thing. So theoretically, we have on the y-axis increasing difference in cost. So the cost of A minus the cost of B is it higher, or does it cost less? So you're going to charge more than the standard of care, your new innovation, or you're charging less. And then on the x-axis, it's increasing difference in effectiveness. Really, that's the catch-all for your value. It's more effective. Okay, is it more effective than the standard of care, or is it less effective? You don't really want to be in the less effective side of things, but to complete the model, we talk about this. So let's go up to number 1 here, top right-hand quadrant. It's more money, so you're more expensive, and you're more effective. So are you cost effective? We don't know. The shrug is the right answer. I don't know. It's more expensive, okay, but it is more effective. Okay, so then there must be some value I'm getting if it's more expensive. So then it comes back to our grocery conversation. Am I going to go to Loblaws because it's more convenient? Is that convenience enough value? Let's see. Okay, number 2 is you are more money but less effective. Are you cost effective? No, that's a pretty easy one. Number 3, you're less money and you're less effective. Are you cost effective? Maybe. Another shrug. Could be. I'm not sure I'd be too interested in less efficaciousness, but yeah, perhaps. And then the 4th quadrant You're less money but more effective. Are you cost effective? Sure. You're giving me the name brand bread and it's half the price of the other. That's, yeah, absolutely. So what health economists do to figure out, so great, quadrants 2, quadrant 1, we're good. Cost effective, not cost effective. These ones are a bit fuzzy. And so the health economists just draw a line straight through and say on the top, you're not cost effective, and on the bottom, you're not cost effective. And so that value assessment, this is where you really focus, and predominantly here, because any self-respecting company that's coming out with a new innovation, it's going to be more expensive. Yes.
What if you're online?
Well, this is all theory.
Okay.
So there, from a therapeutic perspective, I'm not sure if I get into this later, but drugs have a completely random, picked out of the air threshold, which is $50,000 per quality adjusted life year, which is just an economic number. And if you meet that number, then you're considered cost effective. Oh, unless you're a cancer therapeutic, in which case we'll pay double. So it's all theoretical and frankly a bit random. There are other kinds of cost-effective analysis as well. So there's something called ICER. Again, you want to be one of the cool kids, you can talk about ICER, which is incremental cost ratio, which is simply what we talked about, right? Difference in cost versus the difference in effectiveness will give you your ICER ratio. You could do a cost benefit analysis, which measures money, and you could do cost analysis, cost utility analysis as well. But ultimately it comes down to the very basic thing we talked about, which is what is the value you're providing and how much do I have to pay? And then we make an assessment if that is worth it for us. And if it's worth it for us, we call it cost effective. Now, who does HTA? Yes.
Sorry.
Did I lose you?
No, just a question. Maybe it's stupid, but how willing are payers to pay things or pay for reimbursement on solutions that are with high impact or high, what was the effectiveness,
Effectiveness, yeah.
but also at a high cost?
So
Like if there's
the
a,
vast majority of innovative technologies will be some of the commodities, you know, like rubber gloves, maybe you can, same efficacy at a lower price, that sort of thing, but most innovative where you guys are going to be playing, where you're doing something different and you're solving a problem, these are going to be innovative things, and almost exclusively it will be more expensive, but there'll be some value. So payers are very willing to look at that. But the standard of getting reimbursed is becoming more difficult because they're taking a more, they're giving those decisions more scrutiny. Right? Yes.
I just want to give you example.
Mhm.
For example, the Da Vinci, I don't know, it's a robotic surgery.
Yes.
It's super expensive,
Great
but
example.
super amazing.
Yeah.
So that is a great example. The high cost, but it's also high value propositioned. And save surgeon to time, and that's also making the operation much easier. So I
I
think
work with a
that's-
company called Proteosate AI. It's a diagnostic, it's not really that, it's more prognostication. So oral cancer, 70% are diagnosed late stage, 50% mortality rate. It's awful. So this is a very cool technology where they can say that you are fine, you can go away, you don't worry about it, but I'm at a high risk of cancer, so I need to be checked every 3 months. There's nothing, the current standard of care is something my grandmother would use, which is the dentist will look at it and say, yeah, send it to the pathologist, they'll take a little slice and they'll look at it and they'll say, So it's something completely new. It's way better than the standard of care. So there's another example of where it's going to cost, but they have to make that assessment as to whether it's worth paying for.
Just to follow that question, actually, Mark, I'm just thinking, how about certain things in that category, but also less patient population, like what you just said, rare disease, even though it may be give you a good value, but it's
Yeah.
high cost, but also because your patient population is really small. So is that getting more scrutiny than the bigger patient?
That's why they're coming out with a rare disease strategy. That's why they've invested money, because there's a recognition that as we get into these rare diseases and are really successful at treating them,
But by
small
not-
patient population,
Yeah,
by very nature, the economics means that the price of them have to be higher, and in some cases, much, much higher
yeah.
than your sort of standard blood pressure pill. Yes.
So this might be off topic, but it's related to what you just mentioned about this company work with the oral cancer.
Mhm.
So for something like that, they're developing, is it presumably some sort of like image thing? So
Yeah.
Okay, presumably they're using some sort of neural network to do this, and it seems to me that the price in this would mostly be in training, like training the models. But then once it's delivered to the clients, how much money could it cost? Like, you have some-
Very similar to a drug, right? Where you have the research and development
Mhm.
costs are all up front.
And then it's like
The
a
actual
subscription
cost of the ingredients,
is minimal, yeah.
minimum, peanuts.
Yeah.
So yeah, it's the same, it's the
So
same.
but the reimbursement strategy for something like that would be like a subscription service or something.
It's a per test. It
Okay.
happens to be a per test.
Okay.
Yeah, you could do a subscription model as well, but in this case, it's a charge for each test.
Okay.
Yeah. So health technology assessment, there are at least 40, I did this slide a couple of years ago, so maybe more than 43, that do health technology assessment for medical devices. Now, here's a couple of things you need to know. You don't have to do a health technology assessment. So it's by medical device. These are one of the things you want to think about as you're going early in your career, early in your company development. Do we want to do a health technology assessment? So if it's positive, it might help you get reimbursement, but it costs a lot of money. There's no guarantees. Maybe it's negative. So there's lots of with drugs, it's a very clear process. Medical devices, there's thousands approved every year. And so authorities are having a really difficult time formalizing this process. There are so many that are doing this, which is why I have this picture here. And we have 3 chocolate bars. If anyone can tell me what show this comes from. Gravity Falls. Did you already get a chocolate bar?
Not me?
Yes.
No.
So we have Coffee Crisp, Snickers, and Kit Kat.
Let's go with the coffee crisp.
Coffee Crisp, yeah, that's my favorite. Well, caramel's probably my, yeah, anyway, I have a lot of favorites. Yeah, Gravity Falls is a great show. This is Grunkle Stan and his bottomless pit. And it really is bottomless. They keep falling and falling. And so health technology assessment is a little bit like that. There are lots of organizations doing it. There are 2 that are worthy of note. One is, sorry for the small print, but Canadian Agency for Drugs and Technologies in Health, now called the Canadian Drug Agency, CDA. So they mostly do drugs, but they're getting more and more into medical devices, the CDA. And then there's Health Quality Ontario, which is Ontario focused, does very good health technology assessment. When you're looking at value for money, you may want to think about hidden costs. So, for example, I worked for Alcon, which is an eye care company. They had this amazing laser for cataract surgery. I gave a perfect circle cut to remove the cataracts. The challenge was that at the time, it was probably about the size of the table. It actually had to have a separate room. And so there were construction costs involved. So it was one thing for the hospital to purchase it. There was another to find a place for it to go. So the machine itself costs X, but then there was the infrastructure, changes to the infrastructure that had to be considered. So it could be training, infrastructure requirements. Is there an impact on someone's livelihood? We used a radiology example earlier, and we're going to get into fee codes later as well. But hidden costs can be part of this as well. Okay, so let's go to level of advocacy. We talked about stakeholders, understanding your impact. And so this is something that I call a wheel of influence. So in the middle, you have your decision maker or decision makers in the middle of this wheel. And then the outside are the categories of stakeholder that you're going to want to you're going to want to understand what the impact is on those groups of stakeholders and the individuals and organizations within those buckets. So bottom left-hand side, we have media. So they are a stakeholder. We've all seen stories of cancer drug not being covered on the front page of a newspaper. I'm dating myself a bit saying newspaper, but you get the idea. So media, and that is more broad. That's social media. That's print. That's broadcast. Traditional media. All part of that group. We go up to the right to 10 o'clock. Patient groups and advocates. So if you type in to a Google search a disease state and then follow it up by a patient group, followed by Canada, a patient group will appear. They're ubiquitous. They're important organizations and can be really helpful in your journey. So think of the Heart Stroke Foundation or the Canadian National Institute for the Blind, which is just down the street. Those are patient groups. Canadian Cancer Society. There's Diabetes Canada. Lots of those are some of the big ones, but there are lots of small ones as well. Lots in the rare disease space. Up at the top, economic stakeholders, things like the Ontario Chamber of Commerce, Toronto Board of Trade, those sorts of things, Economic Club of Canada. Then we get in at 1 o'clock there, the political side, the politicians and their advisors. We're going to talk a little bit more detail about them, and the bureaucracy. So there's a political side to government, and then there's a bureaucracy side. I'm going to take a couple minutes just to explain the difference. But you can potentially, your medical device can have an impact on all of those groups and within those groups. And I call it a wheel because you have all of these influencers on the decision makers, but they also, each of these categories will interact and influence the other categories. So media can influence the bureaucracy. The bureaucracy can influence the political. The political can potentially influence patient groups and vice versa. So there's a whole a set of interactions here, which is why I describe it as a wheel. You've got those connectors on the outside. So that is the level of advocacy, and I want to go into the politicians versus bureaucrats. I wonder if I can move, just see if I can, just move that down. These are the two most important politicians, two most important people in politics in Ontario. Everyone can name the person on the left. Can anyone name the person on the right? No one's gonna get it. And I've even forgotten their name. I don't have my notes. D'Emmanuel, I think. Oh, shoot. So the person on the left is Premier. Right, that's Doug Ford. He's the political side. He's the most important politician in Ontario. On the right is the Secretary of Cabinet. What a name! Secretary of Cabinet, the second most important political person in the province. She's the head of the civil service. So super important. Nobody knows who they are. So there is a big difference between the political side and the bureaucratic side. So politics, 1,000 politicians or so, and their staff. So each, the premier he'll probably have a staff of probably about 20, 25 people in his office. Minister of Health, maybe have a dozen. If I'm just an MPP, I might have I'll certainly have a constituency office with probably 3 or 4 people. So these are staff, and really those are the ones that govern that small group, and they lose their jobs potentially every 4 years, right? So if the premier goes, then all of his staff go as well. The structure is divided into different ministries, right? So you have the Ministry of Health, you probably heard of, Ministry of Transportation, Ministry of Education. The government's divided up into pieces, and each ministry will have a minister that runs that organization. Their primary role is policy. So by policy, think of, I have an idea. I want to build a road, or I want drugs to be free. So there's this thing called pharmacare. So that's a policy. Well, somebody's got to implement that idea. It's just an idea. And for lots of time, for a certain amount of time, it was being debated and tossed around. So governments do policy, and there are places in front of the camera. They take the credit, they get the blame, and I have power with a question mark, because there's this question as to who might have more power. The bureaucracy, rather than 5 or 10 who actually are governing, with 1,000 total, you've got 60,000. So these are all the people who they're running the hospital, or they're manning the Service Ontario outlets. So they're doing all of the implementation, right? So their primary role is the administration. So it's the implementation of policy is their primary role. They have jobs for life, theoretically. The structure is the same. It's mirrored the bureaucracy. They stay in the shadows. We have no idea who Michelle is, but we sure know who Doug Ford is. So that's the difference between the politician and bureaucrats. And when it comes to medical device reimbursement, you need to understand if you're dealing with a political issue, or are you dealing with a bureaucratic issue? Are you dealing with a policy issue, or are you dealing with an administration issue? So, and pharmacare, I suppose, is a good example, where that was, if you wanted to advocate for pharmacare, that was a policy issue, so that was straight on political. As we now have legislation passed, and it's now being implemented, now becomes a bureaucratic issue. So if you want to influence that, you're probably better on the bureaucratic side. Although of course there is some overlap. So that's a quick couple minutes on government relations. Yes.
What's another example of an administrative barrier if you're trying to get your medical device into market, or like into Ontario at least? Like, who would do the assessment of your device? Is it a bureaucracy or a political?
So yeah, who will do the assessment? So it might be somebody in the hospital. It might be somebody in a long-term care facility. There's programs for home medical devices, and there's a body that does assessments if it's a medical device used in the home.
Mhm.
So the answer to most questions in this lecture is the same one I'm going to give you, which it depends. So this is the challenge with medical devices. And so with that, we can get our reimbursement. Again, thinking in terms of the payers. Now we're going to get more specific. So I think we're going to get to answer your question. This came from a report, Healthcare in Ontario, from a few years ago, 2017. But I really like this graphic because it portrays how payers are thinking about medical devices. And so they're thinking about medical devices and the reimbursement of those in a couple of different ways. So you have indirect commodities. Those are things that are commodities that don't touch patients. And then there's direct clinical commodities. So rubber gloves, for example, office chairs. So those are things that there's no innovation, they just go and they buy. And the light blue, they're purchasing them for price.
Okay, and that goes up to medical technology as well. So there is medical technology. I gotta be careful what I say, because every time I would say a medical technology, someone could come up, I'm sure, with an example of where there is innovation. You know, things like maybe like syringes or hospital beds might be a good example. Although again, with hospital beds, there's all kinds of technology that's now going into them, which are putting them into that outer category. But for a time, they were medical technology that was purchased for price. And now this very light blue is purchasing products for products and services. They're evaluating the price versus, they're doing that health technology assessment. Is there value for money? And so some indirect commodities are part of that category. Some indirect clinical, certainly in medical technology, we're seeing lots of it. And then we have that peak area of innovation where it is truly something new and different. Perhaps the robotic technology is a good example. Certainly proteosite AI, the prognostication for oral cancer would be a good, where there's nothing being done like this before. And that's true innovation. We're gonna see a ton of this in AI. It's unbelievable what's happening. But that innovation can also be seen all the way down, decreasing as we get into indirect commodities. So this is, if you're putting yourself in the shoes of somebody who's paying for your medical device, this is the thought process that they're going to be trying to put you in a spot. And of course, what you want to be is in that dark blue section. Yes.
Yes, quick question. With regards to the light blue, I noticed you distinguished between price and cost. What is the difference between the two?
They're evaluated. Price, cost, and value. Good question. This is directly from the report. So they might be talking about some of the hidden costs. So is there a requirement for physicians to get paid for using that medical device where they didn't have that cost before? Or is there some additional infrastructure that needs to be purchased in order to take advantage, or more nursing time? So there's the price of the unit, but then there's the cost associated with using that unit.
And or maybe disposable requirements.
Stewardship Ontario, sure, you've got to pay for how you dispose of this. So yeah, there are all kinds of costs that might be associated with. I'm assuming that's what they're referring to there. Most medical devices are purchased by hospitals and long-term care, in which case what you want to do is you want to find a clinical champion. So insofar as there is a process with medical devices, innovative medical devices, and insofar as there's the first step, it would be to find a clinical champion within hospitals, because it's a hospital by hospital decision. Some hospitals are grouped, and we'll talk about group purchasing organizations in a minute, but you really want to find, this goes back to the advocacy, right? Going back to the advocacy, the model level of advocacy. Identify a nurse or doctor who can champion your clinical benefits. Yes.
In order to do something like that, would you recommend like what you suggested earlier by going to different conferences?
That would definitely be part of it. Absolutely. Yeah. Yeah, that's a great, from a financial perspective, it's fighting strategics, but certainly one of the ways to promote your product is what I would call a podium presence. So you've got some key opinion leader who's used your device 4 times and presents those case studies at a clinical conference saying, oh my God, this is the best thing ever. You're going to have an easier time after that conference than before with respect to gaining interest, your commercialization journey, and your reimbursement. Yeah. So you can get a clinical evaluation done at individual hospitals. Yeah, this is a complicated slide. medical device reimbursement is complicated. So this was from the same report, by the way, as that the previous the triangle slide. So I'm going to simplify this. You've got the vendor. This is the person who's selling. You've got the source, who's the middleman, and then who's procuring it. So this is your company over here. You've got middlemen to deal with, and you've got the people that are actually doing the procuring. To simplify this, I'm going to focus on two areas. On the procurement side, hospitals and long-term care. Vast majority of medical devices go through those two organizations, and the vast majority of their products go through shared service organizations and group purchase organizations. Those are simply buying groups. So they buy for lots of hospitals, and so they have more purchasing power, so they can get a better price, and they pass some of those savings on to the hospital, and they put a little bit in their pocket, and everybody's happy. So you need to be aware of shared service organizations, group purchasing organizations, as I say, hospitals and long-term care. The vast majority of medical devices are paid for. There is some direct government reimbursement. So again, depending on who you're impacting will determine where you're going. Maybe you're not in a hospital. Maybe you're an assisted device for home care. Chances are you might be both, but there is a specific program called the Assisted Devices Program, ADP, this is Ontario, but there are examples across the country where they will pay 50% of the reimbursement the patient 50% of the cost of a wheelchair, of handrails, of a stair lift, and home care. The home care market is exploding because we can't afford to build any more hospitals. So there is a strategy to have more and more care in the home, which means more and more medical devices in the home. So Assisted Devices Program. There's also the Ontario Government Pharmaceutical and Medical Supply Service. The example of the naloxone kits. You go to a pharmacy, you say, can I have a naloxone kit for an overdose kit? They'll give you one, say, thanks very much. Someone pays for that. It's this program, it's the Ontario government. You get reimbursement through that program. Government funding priorities, we talked a little bit about that. Strategic political objectives announced by provincial ministers of health or local administrators are something to keep an eye on as well. Alternative payers. We've got private healthcare organizations. So things like executive, you guys heard of those programs for, let's say executive, it's really people who want to pay. They can have a private, almost a concierge service where they can get full assessments. It's not Medisys, Medcan, any of those ring a bell? Yeah. So you pay $3,000 and you can get full workups. So those are an example of private healthcare organizations. Allied healthcare professionals, so chiropractors, podiatrists, those sorts of groups. That might be where your medical device is paid for. Private insurance companies, regional health authorities, hospital or charitable foundations. If you're selling MRIs, chances are you're going through the charitable foundation because those things are really, really expensive. So they'll likely raise some money specifically to purchase a new MRI. Private donors, and of course there's direct to consumer, right? You go into Shoppers, it's filled with medical devices. Blood pressure monitors, that's a medical device. We're not really talking about class 1 medical devices, but as they say, toothbrush is a medical device as well. So those are some of the alternative payers. Billing codes. Don't forget about billing codes. So billing codes. So Canada and the US is a fee for service, which means I perform a service. I'm a doctor, I see you for 15 minutes. You tell me what your problem is, I write you a prescription. I performed a service and I get $35 or whatever I get. If I perform cataract surgery, it's fee for service. I'm gonna get a fee for the surgery. And so there are medical devices that may require a physician to do something. And if it requires a physician to do something, then there is a billing code which allows him to get paid for that service of doing that something. That's all great if your medical device fits into a current billing code, fits into a current service. But we're in the innovative space, so it's not unfathomable for there to be no billing code. So if you don't have a billing code that allows the physician to perform the service and use your medical device, you're gonna have a much harder time with adoption, right? Because the physician's not getting paid for performing the service. So you need to figure out if you have a billing code, and if you don't have a billing code, if you need a billing code, it takes a long time to get that figured out. And that can be a political piece, that can be talking to the bureaucracy, that can be talking to stakeholders, that can be talking to physician groups like the OMA, right? They're the ones that negotiate contracts. So there's a whole process to getting a billing code. You want to understand early on in the process whether or not you need a billing code, and if you need a billing code, do you already have one based on what you're doing? Make sense? Do we want reimbursement? Yes.
Sorry, so just as an example of billing code, when you say, do you already have one, is there a product that's sufficiently similar to what you're doing?
Precisely.
Like what you were saying with the mouth cancer and drugs, like you could adopt their billing code?
Yes. So in that,
model it after it or something?
in that case, in that case, that's not a good example because the physician actually doesn't have to do anything extra. So there is no change, that we just use the pathology slides that have already been taken. I'm trying to think of an example where, I worked with a client, had a heart monitor. So current standard of care, I've got blood pressure. The doctor is a little bit concerned. He wants me to wear a 24-hour Holter monitor. So I get this big thing and I strap it on and I carry it around, and I've got a bunch of leads. And then I take it back and I give it to him, and he downloads the data and then he looks at the data. So this thing is super cool. So it's a little tiny thing strapped on your chest, had like 3 or 4 extra leads, real-time communication with a nurse's station, so they could actually monitor what was going on. And like this thing is really, really cool. Now, it was more expensive because the technology to go into it was, more convenient for the patient, et cetera, et cetera. It was real-time monitoring, and they had people doing the real-time monitoring. So all that's fantastic, except when you go to commercialize and you look for your billing code, right? And labs have billing codes, by the way, too, right? So the billing code for a physician organizing this, or a lab organizing this Holter monitor, was about $25. Well, they couldn't make a business out of $25. It needed to be like 75 or 100. And so it was dead in the water. They hadn't thought about that beforehand. So there was a billing code, but it was insufficient. So you got into that.
Right, so that's like an idea that's just, even though it's great, it's just never gonna work.
It's not that it's never going to work. It's just it's going to take more time. And I'm sorry, we're over time, so I have to wrap it up there. I'm happy to take more questions, but if you have to go, feel free to.
I was just gonna ask,
Yes.
what's the process for how billing codes get created? Like if you are doing something really innovative.
So the OMA, the Ontario Medical Association, is the one that negotiates billing codes.
Okay, and is it like synchronized with these, or is it a
Oh, completely separate. Yeah, completely separate. Yeah, it's different by province. Yeah. Yeah, so happy to have further conversations. If you've got specific questions. And thanks again for joining us today.
Thanks, Mark.